Hi folks, this is Dr. Rob Sivis. I am the Carb Addiction Doc, and today, at least according to convention, I'm going to go out on a little bit of a limb, and I'm going to pose a question. And the question is the whole statin industry, is the whole statin world a fraud? A fraud. Is it based on lies and smoke and mirrors? Is it a fraud? Now, this is not a knee-jerk thing. It's not just a belief. I'm basing the question. Is the statin industry, is the prescription of statins, is the scaremongering of people about their cardiovascular risk warranted? And is the use of statins and the prescriptions of statins justified by the data, by the real data? Or is the data being manipulated so that we can scare the crap out of our patients into taking a lucrative drug that really has no value or potentially liability? And I'm going to not answer the question, but I'm going to provide the data. I'm going to provide the true statistics. Because recently, two major publications have been put out there. And I've got the publications right here. These are just the copies, the outlines. I've got the full papers. The first paper is a brilliant paper written by Paula Byrne, Marianne Demasi, Mark Jones, Susan Smith, Christy O'Brien, and Robert Dubroff. And it was published in JAMA Medicine earlier this year. And the title of the paper is Evaluating the Association Between Low-Density Lipoprotein, LDL, cholesterol, the bad cholesterol that your doctor will say, evaluating the association between LDL cholesterol reduction using a statin and relative and absolute effects of statin treatment. In other words, if you're on a statin, if you've got a high LDL or an elevated LDL and you take a statin, what is the benefit? Now, this did not look at all at side effects. There are papers out there, plenty of papers, looking at the increased risk of diabetes, the increased risk of dementia, the increased risk of gastrointestinal and joint and bone pain. This doesn't look at the negative side of statins. This looks at the benefit of statins, both to prevent cardiovascular risk, and if you've already had a heart attack or a stroke, what is the risk? What they call the secondary risk. In other words, if you've already had a cardiovascular event, they call it secondary prevention. So does the use of a statin reduce a second event? Does it prevent a first event? And the second paper I'm going to look at is a paper that was published by three authors who are colleagues of mine, David Diamond, Dr. Benjamin Bickman, both of those are Ph.D. doctors, and Paul Mason, an MD out of Australia. And the title of that paper was just published in August of this year, just a few days ago, in Current Opinions of Endocrinology, Diabetes, and Obesity, is titled Statin Therapy, and this is powerful. Statin therapy is not warranted for a person with high LDL cholesterol on a low carbohydrate diet. And they break down the data, and I'll go through that data with you. But also a study is being done by another person by the name of Dave Feldman, using people with super high LDL cholesterol who are lean mass, normal weight, and have high LDL on a low-carb diet, and looking at a study over the course of a couple of years, studying imaging their cardiovascular system, the blood vessels, to see if there is a clogging of their blood vessels because they're on a high-fat diet, because their cholesterol, the LDL cholesterol, is high. And the study is done over time, and they'll see if there's an increase, a decrease, or a flat line in terms of cardiovascular risk. But it's the vascular side, the plumbing side. None of these studies look at the electrical side, the arrhythmia sides. I've got to talk out there on that. That's a separate debate. But this is cardiovascular risk, and specifically about, are statins a fraud? And the first paper, excellent paper, in terms of what it's set out to do. I'm not going to make a judgment on the paper, but it's a really good, robust paper. What they did is they assessed the association between absolute reductions. So if I've got one person and I've got another on a statin, a group of people on a statin, a group of people are not on a statin, what is the risk of a heart attack or a stroke in this group, and what is a risk of a heart attack or a stroke in this group, and is there a difference? That's absolute risk, okay? With the treatment of statins, and they looked at all-cause mortality. I don't care if you were run over by a truck, died of COVID, or died of a heart attack or a stroke. Then they looked at heart attacks, and they looked at stroke deaths. And they felt that this evidence, this information, done in an objective way, presented objectively, is very important to your physician and to you as a patient in order to make a better informed clinical decision about whether statin therapy is appropriate for you or not. Because the problem is that these studies have been distorted in their data presentation to favor the use of a statin when the data doesn't support it. What do I mean by that? So what these trials did, they looked at the same studies that your doctors use, but they looked at large randomized clinical trials that examined the effectiveness of statins in terms of reducing total mortality, cardiovascular outcomes, with a planned duration of 2 or more years. So good studies that reported absolute changes in LDL value that correlated with the reduction in heart attack, stroke, and cardiac event, and all-told mortality. And when compared with a placebo, and they looked at this from two perspectives. They looked at the absolute risk, and then they also looked at the relative risk. In other words, they looked at the people who did die between the two groups, and they compared them. So you've got absolute risk and you've got relative risk. And the only thing that counts is absolute risk. What's my risk of dying if I don't take a statin? What's my risk of dying if I do take a statin? That's all that matters. Okay? So they looked at 21 trials, same trials that your doctors are using for convincing you should take a statin, and they did a meta-analysis. And they showed absolute risk reduction. So if 100 people are on a statin, if 100 people are not on a statin, 0.8% was the absolute risk for all-cause mortality, the risk difference. 1.3% was the absolute risk difference for heart attacks, and 0.4% was the absolute risk difference for stroke. None of those was statistically significant in any way. No statistical difference. And this is 21 studies. Meta-analyses have the strongest information. They pool huge amounts of data. 0.8%, 1.3%, and 0.4% for those randomized to treatment with statins. However, so 0, no, or 0.8, 1.3, 0.4% difference, not statistically significant in any way for absolute risk. However, when they looked at relative risk, the relative risk in the same studies was 9% for all-cause mortality, 29% for heart attacks, and 14% for strokes. And the meta-regression exploring the potential mediating association of the magnitude of statin-induced LDL-C risk. In other words, when you analyze the statistics to determine whether there was a benefit to taking statin in terms of reducing LDL-C, the outcomes showed that it was inconclusive, that there's no conclusion, that there really isn't any determinable benefit. So they concluded in the study that the result of this large meta-analysis suggests that the absolute risk reductions of treatment with statins in terms of all-cause mortality, myocardial infarction, and stroke, which is the important thing to make a decision, am I going to take a statin, are modest compared with the relative risk reductions. And the presence of significant heterogeneity, differences in the populations, reduces the certainty of that evidence. A conclusive association between absolute reductions in LDL-C levels and individual clinical outcomes was not was not established. And these findings underscore the importance of discussing absolute risk reduction when making informed clinical decisions with individual patients. So when your doctor gets pissed off with you that you say, I don't want a statin, ask them what the data is. And they'll say, oh, there's a 34%, there's a 29% risk reduction. That is a relative risk which means nothing. Ask them what the absolute risk is. They won't know. They will not know. Show them this paper by Damasi and et al. Show them the paper. Show them that there is no statistical difference. There's no statistics that support what they're telling you to do. And if they get pissed off at you, whether you take the statin or not, the risk doesn't matter. It doesn't change. And if they're using something that statistically doesn't benefit you or harm you, and they base their relationship on you based on that absence of evidence, I'm not going to answer that. But how many of my patients have not been at war with their physicians about statins, and yet they're taking the very papers that those same doctors have been lied to, because those doctors are genuine. They're not trying to lie to their patients. But the reps in the pharmaceutical companies and the presentation of this data based on relative risk is a fraud. Calm down, boy. If your doctor has been indoctrinated with relative risk by the pharmaceutical companies, that physician, in my opinion, based on this evidence, has been fraudulently corrupted. And that's fine. But when it impacts your health, that's a problem. Because the other thing that goes along with statin therapy is a low-fat diet. Recommendations for a low-fat diet, a low-salt diet. Well, we know also categorically that that's not true because of the second paper. The second paper says statin therapy is not warranted. Not warranted, categorical, not warranted for a person with a high LDL cholesterol on a low carbohydrate diet. So your doctor that's telling you to be on a statin and also recommending a low fat diet is giving you not only ineffective information, but wrong, false information, leading you to harm. And not because they intend to do that, because they've been fraudulently corrupted. In my opinion, based on the data, based on the evidence, because the evidence doesn't support that. The fabricated relative risk in terms of replacing absolute risk is what they base their opinion on. So this paper, people on a low carbohydrate diet, which is what I'm recommending to you, whether you're on a statin or not, I don't care. But the heart and the soul of primary prevention and secondary prevention for cardiovascular disease is not mediated by medication. It's mediated in a lifestyle change. Change why you became a cardiovascularly affected person in the first place. Why do you have that fat in your blood vessels? Not because we eat fat, not because we're producing cholesterol in our liver, but because sugar is damaging our blood vessels. The fat in our blood vessels is the fireman, not the arsonist. The arsonist is your carbohydrate consumption. And this paper here by Diamond, Bickman, and Mason says that statin therapy is not warranted based on the evidence for a person with high LDL cholesterol and a low carbohydrate diet. They say, although there is extensive literature on the efficacy of low carbohydrate diets for weight loss and the management of type 2 diabetes, concerns have been raised that the low carbohydrate diet may increase cardiovascular disease. Ludicrous. By increasing the level of LDL. So everybody gets healthy, but the LDL goes up. Oh, it's bad for you. We've seen the evidence that that's not true. We have assessed the value of LDL-C as a cardiovascular disease risk factor, as well as the effects of low carbohydrate diets on other cardiovascular disease risk factors. We have also reviewed findings that provide guidance as to whether statin therapy would be beneficial for individuals with high LDL-C on a low-carb diet. So if your LDL is going up and your doctor's all worried and they want to put you on a statin, read this paper, give this paper to them, give this paper, the other paper to them. And the findings are that multiple longitudinal trials have demonstrated the safety and effectiveness of low-carbohydrate diets while also providing evidence of improvement of the most reliable cardiovascular disease risk factors. I see that in my own practice. I practice that way. That is the fundamental objective of my practice, is to make those cardiovascular risk factors and other risk factors better. And we track those with your blood work. So if you want that, give me a shout. Recent findings have also confirmed how ineffective LDL evaluation is at predicting cardiovascular risk. Now, I'm going to come to that in 1 second. So the summary of this paper is that extensive research has demonstrated the efficacy of the low-carbohydrate diets to improve the most important cardiovascular disease risk factors: your triglycerides, your insulin resistance, your type 2 diabetes, your low HDL, your obesity, such as hyperglycemia, hypertension, and atherogenic dyslipidemia. Our review of the literature indicates that statin therapy for both primary and secondary prevention of cardiovascular disease is not warranted for the individuals on a low carbohydrate diet with elevated LDL-C who have achieved low triglycerides and a higher HDL ratio. So the holy grail of a low-carb diet is to drop your triglycerides, elevate your HDL, drop your insulin, drop your A1C. And then what happens with your LDL, it'll go up, but it doesn't matter. So it is true that if you've got high triglycerides, low HDL, and high LDL, but you're eating a bunch of sugar and starch, you're at high risk for cardiovascular risk. But if you lower your triglycerides by a low-carbohydrate diet, getting rid of the sugar and starch, becoming insulin sensitive, your triglycerides will go down, your HDL will go up, your LDL will paradoxically go up, but that's healthy. That lowers your risk. Don't need a statin. So, okay, let's look at this another way. Let's look at, and this comes from Professor Tim Noakes, who's done extensive research on the science behind some of these things. And we're in a small group of scientists that go back and forth. And this whole conversation, I'm quoting now, this whole conversation is in many ways, the conversation about LDL-C and cardiovascular risk and statins is in many ways technically absurd. Okay? Why? Well, one of the things that our group doesn't understand about the fetish of the cardiologists and your family doctors with lipids as a predictor of future cardiovascular risk is that most of the data, as we presented so far, comes from association and prospective studies in which the magnitude of risk is measured as the hazard or risk ratio. Okay? That's a statistical term. So let's go through, what does that mean? There's a guy called Bradford Hill, and it's the Bradford Hill criteria, who's written extensively on what level of hazard risk, how much risk is meaningful. And he has written extensively on what level of hazard risk can be considered to indicate a causal relationship. So you may have an association, okay? There may be an association. Every time the wind blows, the sun shines. But the sun doesn't shine because the wind blows. Okay? Those are an association, not causal. But if you remove your heart from the chest, you will die. That's causal. I know it's a stupid example, but it's causal. Okay? So there's a big difference between causation and association. But how do you tell the difference? If you've got two studies, how do you tell the difference between two variables? And the Bradford Hill criteria state that, for example, the hazard ratio, and this is interesting, this is very interesting, the hazard ratio between cigarette smoking and cardiovascular risk, cardiovascular is heart attack risk, is statistically a 2. Which is probably too low to be absolutely certain of a causal relationship. Now, I'm pretty certain in my belief that cigarettes cause or contribute to in a causal way to cardiovascular risk. But statistically, a 2 is not proof. However, Because Bradford Hill believes and has shown statistically that 5 is the number. So 2, which is a pretty decent number, is not good enough for Bradford to say cigarettes cause cardiovascular disease. But if you're at 5 or above, that's absolute. That's incontrovertibly causal. So he found that hazard ratios greater than 5 for the relationship between cigarette smoking and lung cancer. In other words, a 2 for cigarettes and cardiovascular disease, but 5 plus for cigarette smoking and lung cancer. So absolutely, smoking is causal to lung cancer. Now, there are other lung cancers that you can get that are not caused by smoking, but if you smoke and you are lung cancer, that is a causal relationship. It's highly likely it's causal for smoking, but it's not absolute because it's a 2. Okay? So let's look at these numbers. So 2 is kind of the threshold of maybe, and 5 is the absolute. So no one is likely to question hazard ratios of this magnitude above 5. 5 is causal. Okay? And Bradford Hill has 8 other criteria that he uses, and all those other 8 criteria are important in supporting that hazard ratio. So the question is, what is the highest hazard ratios in terms of causality or association for lipids and future cardiovascular events, heart attacks? And in the literature, the highest, the best possible hazard ratios associating lipids, LDL, fat in your diet, fat in your blood vessels, with cardiovascular risk is 1.3. Purely an association, no causal relationship pretty much whatsoever. If 2, cigarette smoking to cardiovascular disease, isn't even highly likely, isn't even absolute, then a 1.3, risk is extremely low. The likelihood is extremely low that lipids cause cardiovascular disease. Here's what's interesting. When you look at the hazard ratio of type 2 diabetes, so your A1C is above 6.5, if you have type 2 diabetes, your risk of future heart disease, and this comes from the Women's Health Study, so it's in females, is greater than 10. 5 being causality. So it's absolute. That type 2 diabetes, insulin resistance, carbohydrates cause insulin resistance, that insulin resistance type 2 diabetes is causal of cardiovascular disease. But all those doctors out there, all those wonderful people out there that are treating patients, that are scientists, that are cardiovascular doctors, ignore the diabetic risk or don't address it and focus on a lipid risk that doesn't exist. They should have a big club at the entrance to their practice, and anyone that comes in with diabetes, they should whack them on the head and not allow them to leave until they're addressing their diabetes. But instead, that same club is used, bonk, you're not allowed to leave until you're on a statin. They're treating a disease that is at best associative, certainly not causal, and they're adamant about it. And yet they ignore the diabetes. Oh, your blood sugar is 160, lose a little bit of weight. That's where they need to be focusing if they want to reduce cardiovascular risk. They need to be beating you down and forcing you, at least with as much force as they try to force you to take a statin, to treat your diabetes. But they don't. They don't. Oh well. If you are not already treating and preventing or reversing your prediabetes or type 2 diabetes or insulin resistance, you're going to get cardiovascular disease. And then our discussion went on to talk about CAC scores, coronary artery calcium scores. And basically said, what's the point of getting a coronary artery calcium score? Oh, it's negative, therefore I can keep eating carbohydrates. It's a 10 times hazard ratio. And I know it's science, but that's really bad. Don't care who you are. So a low carbohydrate diet, treating your diabetes aggressively with medication and a low carbohydrate diet, because the medications don't put it into remission. The medications help to accelerate the rate at which a low carbohydrate diet puts your type 2 diabetes into remission. You want to treat your heart disease, that's the way to do it. I hope I've given you some ammunition, some science to call your own doctors out on. But the reality is, just smile, take the script for the statin, and go and find yourself a doctor who understands your biology better. Because you're not going to convince them. Because for every patient that says, I'm not going to take a statin, here's the evidence, they've got 1,000 reps coming in with donuts and cakes and cookies and wonderful gifts and convincing them that relative risk, oh my God, you're going to die if you're not on a statin. And those same doctors are probably taking statins themselves. No different than in the 1950s and 60s when the doctor puffing on a cigarette, offering you a cigarette, said, cigarettes fine, they don't cause lung disease. Your lung cancer is because. If I've made you think, folks, I've done my job. But I'm passionate about this because I see people dying every day of cardiovascular disease or having to leave their doctors because they're in a fight about statins. Not about the evidence, but about whether or not they should take a medication. Look at the evidence. And quite frankly, if you come into my office and say, I looked at the evidence, that 1.3% scares me, I'm going to take, that's fine. Take your statin. I'm not going to argue with you. I'm not going to argue with you. I'm going to advise you it's not necessary, but I'm not going to argue with you. Take your statin, but get the hell away from carbohydrates because that's what's going to kill you. Don't take the statins so that you can eat the carbohydrates. You're still going to die. If you want to take the statin, who cares? I don't. There's risk to it. I'll talk to you about that risk. But get on a low carbohydrate diet. No, don't do that. Treat your carbohydrate addiction. I am a carb addiction doc. If you want us to talk more about this, if you want to individualize this, if you want us to analyze your blood work and give you objective information of what your true cardiovascular risk is by the true criteria, not the LDL, give me a shout. Set up a consultation anywhere in the world. WhatsApp, text, 561-517-0642. The ladies in my office will get with you, set up a consult. It may be a bit of a delay. We're chock-a-block full. I'm one human being. You can also come and see Cheryl, our dietitian. She can help you with certain things. But do something, folks. A pill doesn't do it for you. You can't outsource this. See you next time.